So I'd like to move on then to the next set of speakers. We're very happy today to be joined by the National Association of Community Health Centers, Ellen Robinson, who is the Director of Information Resources and Outreach, along with a health center behavioral health manager, Kelli Bosak, who will make some remarks after Ellen. Ellen, do you want to go ahead?
Great, thank you. Next slide. One more. Great. The National Association of Community Health Centers, we're known by NAC, is a nonprofit membership organization founded in 1971. Our job is that we work to support all of the health centers out there, and we do that by conducting research-based advocacy, educating the public about the mission and the value of health centers, providing training and technical assistance to both health center staff and their boards, and we work on areas such as clinical workforce. We create innovation and aim to improve performance in health centers. Next slide. As Dr. Steinberg mentioned previously, health centers have a very large reach. We are close to 26 million patients served, and we have over 24,000 clinicians. The numbers, as Dr. Steinberg mentioned, are about 1 in 2 across the United States who get their health care from a health center, which is why, next slide, it is very important and a NAC priority to integrate behavioral health with primary care. Given the impact on our patients of opioid use, we've been working on this issue for several years. We've internally formed a work group to discuss ways to combat the issue. We have education sessions both at our conferences and as well as other conferences. We conduct webinars, podcasts, and we're privileged to work with CVS Health and the American Academy of Addiction Psychiatry on several projects. And we've also formed some collaborative partnerships with our health centers, primary care associations in the states, and health center control network. Next slide. Our health centers are doing a lot to integrate behavioral health with primary care and work on the substance abuse issue. PCC Community Health Wellness Center in Chicago is one health center who has a comprehensive program. Those comprehensive programs that our health centers do are working with expanded care teams, working with partnerships, including medication-assisted treatments, pain management through ECHO. There's lots of different ways that our health centers work on the issue, and each one does it slightly differently according to their patients and their needs. So with that, I'd like to introduce Kelli Bosak, who is a licensed clinical social worker and one of PCC's behavioral health providers. She'll be discussing what they are doing in their health center to work with people with substance use disorders.
Good afternoon, everyone. This is Kelli, and I'm going to give a little bit of an example from our work here at PCC Community Wellness about managing the opioid crisis in Illinois and in Cook County specifically. Next slide. So PCC Community Wellness is a federally qualified health center. We're located on Chicago's west side and the near west suburbs in Cook County. Since we were founded in 1980, we have expanded to about 12 different clinics that provide primary care, integrated behavioral health, and in the last few years, we've integrated medication-assisted treatment across several sites, but also an opening a chemical dependency clinic. So we provide the full suite of primary care services as well as behavioral health and other clinical supports. Our mission is to improve health outcomes for the medically underserved community through the provision of high-quality patient care. And next slide. So a little context of the story in Illinois. The opioid epidemic continues to disproportionately impact African-American men and additionally African-American women, and the mortality rates are about 3 times greater for African-Americans and black members of our community than for whites or Caucasians. What we found here on Chicago's west side is that about 1 in 4 opioid-related hospitalizations occur within our community, and these are directly our patients who are serving or the community members, neighbors, family members of our patients. This accounts for about 35% of the total opioid-related hospitalizations in Chicago, so we're seeing a lot of it here on the west side, and about 83% are those who are black or African-American, predominantly around the west side. We're located very close to an expressway that is known as Heroin Highway, and so it often brings a lot of people to the area to use, and also has concentrated a lot of those who have substance use disorders on this side of town. In Illinois, the ability to provide treatment for substance use disorders has decreased in the last 11 years by 52%. And that's the #1 treatment capacity decline in the United States. And so given that, about 61% of publicly funded treatment facilities closed down in the Chicago metro area. So what we're seeing is really high rates of use and a really limited ability to provide treatment, especially in communities that were disadvantaged, under-resourced, and disproportionately affecting marginalized communities, including those who are African American, Hispanic, and Latino. Next slide. Okay, so at PCC, we have an integrated model of care, and to give you a little timeline of where we started, where we've grown, is that in 2007, we started to embed behavioral health into primary care. So we have integrated behavioral health consultants, who are usually licensed clinical social workers or professional counselors, as well as psychiatric nurse practitioners in the primary care setting. Then about in 2011, 4 years later, we started to implement medication-assisted treatment at one of our sites in the Austin community on the west side, which is where the highest rates of substance use and opioid dependence occur. And that was with one prescribing provider, a medical physician, as well as 1 or 2 behavioral health consultants providing the care and treatment. And then over the next 3 years, we increased the number of patients who were seeing, but what we really found is that we needed to expand and really create a program through additional funding and structure to engage patients when they were coming in through the door, as well as to support them in their treatment over the long run. With that, we expanded in 2014 to 2 locations, and then we received grant funding and opened up a chemical dependency clinic at one of our walk-in sites in West Suburban Medical Center in Oak Park, Illinois, just about 2 blocks away from the Austin clinic, so it's right bordering Chicago. And since then, since 2016, so almost 2 years, we've grown from having 4 prescribers who had a data waiver to prescribe Suboxone to over 10, and even now up to 20 to 23, depending on the time of year when we have our residents here or not. And so in 2016, we had about 100 patients who were receiving medication-assisted treatment, and since then we've grown to 2018 to about 300 to 350. So we opened that clinic, and through that we continued to receive support and more people coming through the doors, and we received additional grant funding from the Office of Women's Health and the Chicago Department of Public Health to open a high-risk chemical dependency clinic for women who are currently pregnant or postpartum with a substance use disorder. So we can combine integrated behavioral health, prenatal care, and substance use treatment within one setting. We've also participated in a learning collaborative through the Chicago Department of Public Health to share the information and resources that we have and the lessons that we've learned in launching this clinic and managing it and supporting our patients with other sites and FQHCs in Chicago who are doing this work as well. And now in 2018, we're expanding our medication-assisted treatment then to continuity clinics, so outside of the starting point, which is the chemical dependency clinic, to other sites where they can continue to receive prescriptions, and really with the support of NAC and the CVS Health is to integrate trauma-informed care into the support. So next slide. With that model, we're seeing we've also helped to shift the culture of PCC to integrate trauma-informed care as well as substance use screening. Through that, we've really just been able to identify a higher rate of problematic substance and other substance alcohol-related use disorders as well as mental health concerns through the implementation of universal screenings using SBIRT, and the audit and DAS, which I'll mention a little bit later, as well as the PHQ. So you can see just by screening, we really jumped up in the number of patients we were identifying with related disorders, and we could provide better access to quality treatment for those individuals. Next slide. So to share a little bit about the integrated pathway to recovery for patients who present and identify an opioid dependence or opioid use disorder is that we first start off with that universal screening. So we may identify a patient in primary care who shares a use disorder. We engage them in treatment in an ongoing assessment, usually with behavioral health or their medical provider. We also have individuals who self-refer or just start to walk into the chemical dependency clinic. There's a lot of word of mouth that brings individuals in. When they first come in, they start with induction, so that's the process of getting started on the medication. They have a daily integrated appointment with a behavioral health provider as well as a data waiver prescriber, and they attend visits for about 1 week. We also administer the COWS, so that's a clinical opioid withdrawal symptoms schedule, so we rate, so we can identify what level of withdrawal they're at to provide the appropriate dosage of the medication. Then patients, after they complete induction, they engage in treatment. When they're engaging in treatment, they're having integrated behavioral health meetings at every medication-assisted treatment appointment. So it's a coordinated system of care, and then we also give a rapid urine screen at each MAT appointment as well. When patients enter the maintenance phase, we also include them and give options around individual and group counseling. We have on-site and off-site multiple options for groups and individual work. They still have integrated sessions at their MAT appointments, rapid UTOX, and then we complete ongoing evaluation of their substance use disorders every 6 months. Next slide. So some of those tools that we use for clinical consideration are the ESPERT, so the universal screening for alcohol, drug use, and as well as nicotine dependence, and then the clinical opiate withdrawal scale is used during induction. Next slide. Okay. And the medication-assisted treatment options that we're able to offer are the first two, buprenorphine, Suboxone, or referred to as Subutex. That is, we are usually using Suboxone when we provide it with patients, and most of our patients are on Suboxone. In addition, we'll also provide the naltrexone Vivitrol injection for opioid use disorders as well as for alcohol use disorders, and we'll give that injection on site. And then we do have patients who are on methadone. We don't currently prescribe or administer a methadone, but that is an option for some of our patients, and we'll refer out, and it's not currently available for use in FQHCs. Next slide. Okay. Some of the wins that we've had is that we've started engaging high-risk OB patients in care, so really starting to deconstruct the stigma around substance use during pregnancy and postpartum periods for mothers, and try and get them in and engage in treatment so that they can decrease the health risk to themselves and to the newborn. We are also expanding access to group therapy. We have had open support groups at one of our sites for almost 2 years, and then we've been launching that at 2 other sites, so that increased access to that will greatly help to increase social support and decrease isolation for some of our patients. We've also integrated trauma-informed yoga therapy in a group supportive setting through a partnership with a yoga nonprofit, so it's co-facilitated relapse prevention and yoga therapy for our patients with a lot of chronic pain and other ongoing stressors. And we also have smart recovery meetings at our clinics. In addition, we've expanded partnerships with other substance use disorder treatment facilities, including detox programs, as well as hospitals who are seeing patients come in to the ER for hospitalizations exacerbated by heroin use or by other infectious diseases. We've increased the licensure of our behavioral health providers to include CADC, so chemical and alcohol dependence counseling, I always forget that acronym, and then increasing the data waivers for our medical providers to include not only MDs and DOs, but also APNs. We've also been doing a lot to help get the word out in the community and to really increase access to those things via social media and in local newspapers. Next slide. Okay, and that's actually it. This is an example of one of those postcards that we use. So thank you so much.
Thank you so much, Kelli. Boy, you all are so busy. I'm surprised that you had time for us today, but I think the program that you've shared today is really comprehensive, and that your health center has really worked hard to identify ways to meet the needs of folks in the community. So thank you for sharing all of those great examples.
Produced by the U.S. Department of Health and Human Services at taxpayer expense.